So let's start with the febrile infant. And as I love to say, never trust a baby. They will get sick as stink on you very quickly. Never trust a baby. So we have a full-term newborn born by normal spontaneous vaginal delivery without premature rupture of membranes. Begins to have trouble feeding on day of life 1, followed quickly by rapid breathing, elevated heart rate, and lethargy. The child is afebrile. You obtain appropriate laboratory studies. You are concerned and decide to start the infant on the following regimen. So what is the most appropriate regimen for this infant? Your options are A, ampicillin and gentamicin, B, ampicillin, cefotaxime, and acyclovir, C, ampicillin and ceftriaxone, D, vancomycin and ceftriaxone, or E, vancomycin and acyclovir. And the correct answer is ampicillin and gentamicin. So let's talk about why that is. So let's go through the other answer options and why those are not the correct answers. So you don't want to start acyclovir on this baby because we're not really concerned about herpes. This is day of life 1, which is extremely early. We don't know any risk factors from the mom, and we don't tend to see herpes occurring on the first day of life. The earliest we're going to see it is usually, the earliest reported is day 3, and usually it's a little bit after that. See the herpes viruses lecture for some more details. We don't use ceftriaxone in newborns due to concerns of sudden death. So this has more to do with deposits of calcium ceftriaxone neonatal vasculature from using fluids that also have calcium in them. And then there's the risk of displacement of bilirubin with a theoretical potential for kernicterus because we expect these babies to have some elevated bilirubin as neonates anyway. And then vancomycin would cover group B strep, but we don't know that this patient has group B strep. We also have to cover other possible causes of neonatal sepsis, including E. coli, Proteus, Klebsiella, etc. And so you wouldn't want to use just a gram-positive agent alone, which is what vancomycin is. So the correct answer is ampicillin and gentamicin. So let's go into a little bit more detail on the febrile infant. Before I do that, I just want to provide you with this citation, which is the American Academy of Pediatrics Guidelines for the Evaluation and Management of Well-Appearing Febrile Infants, 8 to 60 days of age. So the reason why I'm bringing this up is because this is a very high-yield guideline. So the febrile infant is a pretty common emergency room presentation and hospital presentation. And you are definitely need to know the various components of workup and empiric therapy and definitive treatment for these babies. So please consider looking at this guideline and reading through it. I'm going to go through the major aspects of the guideline with you here. One thing I do want to mention is that this most recent guideline does break up 8 to 21 days of age, then 22 to 29, and then beyond 30. Really, the difference between 21 and 29-day-olds is minimal. And a lot of people practically who are seeing these babies don't treat a 21-day-old very differently from a 23-day-old, to be honest. And so the two most important categories for you to understand are this first category I'm going to go through, and then the category of the infant who is 30 days of age or older. Okay, so let's talk about this very young infant. 8-day-old, 10-day-old, 15-day-old comes into your emergency room or your clinic. They're well-appearing, they're vigorous, they're feeding, no evident sorts of infection. However, they have a fever of 38 or greater. So what do? These babies, never trust them. So we know that they are less likely to be acutely symptomatic while potentially developing a serious bacterial infection simply because they cannot communicate that. They don't have adequate muscle tone early on for a lot of the symptoms that they may develop. And oftentimes, if they're moving on to lethargy or to poor feeding, you are at a stage of very serious infection. And so it's important to do a workup, even if they are well appearing but febrile. So you definitely want to obtain a urinalysis, a blood culture, and automatically perform a lumbar puncture. And you may, plus minus, obtain inflammatory markers. So why are we automatically performing lumbar punctures in these babies? So if a 4-year-old came to you febrile, you wouldn't automatically get a lumbar puncture. So the reason is multifold. First, infants, the younger they are, the worse their blood-brain barrier is. So if they had a serious bacterial infection, including a bacteremia, the risk of it also involving their central nervous system is really very high. And so if you're looking for a serious bacterial infection with a blood culture, you need to also be looking at the CSF. And in some cases, treatment, depending on the infection, may be different in the CSF versus from the blood. The second reason is that neonates, if you had a 4-year-old coming to you and you are worried about meningitis, you're going to see photosensitivity, you're going to see neck stiffness with muscle tightening around the necks, they're going to be holding their shoulders up, they're going to be really tense, right? They're going to have all of these symptoms. Neonates simply do not have the muscle tone necessary to produce those symptoms in the first place. And so your typical physical exam findings for meningitis in an older child simply are often not going to apply for a neonate. So you have to be highly suspicious for meningitis. So then you have to ask yourself if there's increased HSV risk. And of course, this depends on maternal history. Depending on that, you may or may not send HSV studies. But regardless, you're going to, in any scenario, you're going to initiate empiric antibiotics, admit the child to the hospital until your testing has all resulted. If all of your testing is normal or negative, 24 to 36 hours, including blood cultures and spinal fluid, then you may discontinue antimicrobial therapy. This is an additional chart for the febrile infant 22 to 28 days of age. I'm not going to go through this in detail. The only major difference is that you don't absolutely have to obtain an LP. They give you the option of first obtaining a UA. And then if the UA isn't demonstrating a urinary tract infection, then there's a recommendation to perform a lumbar puncture. Okay, so what about the older infant, the infant 29 to 60 days of age? So the major difference here is, again, you automatically do not need to obtain a lumbar puncture if the child is well appearing. That's because the risk of meningitis in this age group is a little bit lower. And so you obtain inflammatory markers, blood culture, and a UA. If inflammatory markers are increased at that time, you follow all these recommendations. And there's a recommendation that says may perform LP, and that's going to be determined by your clinical judgment. So the key points here are fever and less than 21 days of age. You always, always, always get a lumbar puncture. There's no scenario other than a very obvious other source of infection where you would defer a lumbar puncture. Start parenteral antibiotics and observe in hospital. And for every age group in infancy with fever and well appearing, you get a UA and a blood culture at a minimum. And for every group in this first few months of infancy, if they are not well appearing on presentation, there's a very low threshold to get a lumbar puncture. Okay, so we're talking about neonatal sepsis and serious bacterial infections. So let's talk about the difference between early versus late onset sepsis and really why this matters, why we make this distinction in the first place. So the definition of early onset sepsis, depending on where you look, there's two different definitions. Less than 72 hours of life, so within the first 3 days of life is one of those definitions. And some people do the definition for early onset sepsis within 7 days of life. Late onset sepsis is the opposite. So it's either greater than 72 hours or greater than 7 days of life. And usually it's within the 28 days of life. So the source is why we differentiate between these two. If you have a child with early onset sepsis, like in our question stem, you need to be thinking about a source that was transmitted intrapartum, so during labor and delivery. So this is vertical transmission from the labor and delivery process. So you're thinking bugs from maternal, vaginal, and enteral flora. For late onset sepsis, you want to think more about either nosocomial, so meaning, we did it in the hospital, or community acquired. So you're thinking more environmental and less so acquired from moms. So what are some risk factors for each of these? Maternal GBS colonization is a huge risk factor for early onset sepsis. Prolonged rupture of membranes, chorioamnionitis, so a mother who has evidence of infection during labor and delivery, prematurity, and late onset sepsis, of course, for nosocomial purposes, a NICU stay or central lines, but otherwise prematurity is also a risk factor. Clinical presentation is going to be really variable. And as I said, some of these babies may be well appearing upon initial examination. But an early onset sepsis often includes respiratory distress and episodes of apnea that are unexplained by other factors. Temperature instability. So neonates are not always spiking fevers. They may have evidence. In fact, they often do not spike fevers. The evidence for sepsis may be otherwise, including, for example, hypothermia. And then for late onset sepsis, poor feeding is a really big one. Again, fever or also hypothermia, lethargy, and seizures. So what are the most common organisms and how do we treat them? I separate this up usually by an age group of 0 to 28 days, 29 to 60 days, and 61 to 90 days. In the 0 to 28 day group, you really want to be thinking about that vertical transmission and then some community acquired. In the 29 to 60 days, you're thinking a lot more about community acquired, and certainly even more so in that 61 to 90 days. So in the 0 to 28 days, the major causes include GBS in the United States. This also varies country to country. But in the United States, GBS, which is Streptococcus agalactiae, GBS, or E. coli. Other possible causes include Beardan streptococci, Listeria, Staph aureus, H. flu, Enterococci, Strep pneumo, Klebsiella, and others. So your empiric choice of therapy is going to be tailored to this, and that is ampicillin and gentamicin, or ampicillin and cefotaxime if it's available. If not, ceftazidime or cefepime are also options. The ampicillin is there for a variety of reasons, but one of the major reasons is for coverage of Listeria, and it's also excellent coverage for Group B strep. So then 29 to 60 days, you want to have those in the back of your mind, but now you're thinking more community acquired. So Strep pneumo, still some gram-negatives like E. coli, but you're also now thinking about H. flu, maybe about staph, maybe even about Neisseria. And so your treatment, again, is going to be ampicillin. And then you're going to also do either cefotaxime or ceftriaxone. And then depending on whether you think there is a risk for resistant pneumococcus or for MRSA, you want to consider the addition of vancomycin. And then depending on the risk of HSV exposure, you want to consider the addition of acyclovir. And then finally, your 61 to 90-day infants, you're thinking a lot more about community-acquired pathogens, like your strep pneumo, your H flu, your N meningitis. Treatment is typically going to be a cephalosporin, ceftriaxone, or cefotaxime, and then you want to consider adding vancomycin for resistant pneumococcus or MRSA. All right, so let's talk about GBS disease a little bit, because GBS is so important for us in the world of neonatal sepsis. So this is looking at the incidence of early onset and late onset GBS disease based off of different time points when we made interventions or recommendations. So the solid line is early onset sepsis, and the dotted line is late onset sepsis. And so the most important thing to look at here is that the recommendations from ACOG and the AAP and consensus guidelines and all of those things that we do mostly are impacting incidence of GBS for early onset sepsis. So for GBS, that's within the first 3 days of life. You can see here that it's not really impacting late onset sepsis. Most of these guidelines are around the mother. So testing the mother during pregnancy, treating the mother during labor and delivery if she tests positive for colonization, all of those things. So it would make sense that the disease that's mostly impacted in the neonate are those babies who are getting it early on, indicating that they're getting it from maternal transmission during labor and delivery. Whereas late onset may be more environmental acquired. And that's why perhaps these guidelines are not resulting in that impact. Okay, so then let's look at percent of disease onset in infants by age. So this chart here is looking at the percent of cases and the infant's age in months. And so this first one is less than a week of life. And you can see that the majority of cases of GBS are going to be within that first week of life. So that more early onset sepsis. And then after that, you have a significant tapering off. And these are 1 to 3 weeks and then ages and months. So then you break down that first week of life and you look at 0, 1, 2, 3, 4, 5, and 6 days of life. And you can see that the majority of infants who have disease onset at day 0 or 1 of life of early onset GBS sepsis. Okay, so let's talk a little bit about maternal to infant transmission in the setting where there's no pretreatment. So 25% of women, that's a lot of women, that's 1 of 4 of childbearing age, are GBS colonized. So that means that they have GBS as normal flora, and the testing that we do for that is from the vagina or from perirectal. Okay. So you have a GBS colonized mother, which is 24% of women in the United States. 50% of those will go on to have a non-colonized newborn, and 50% of those will go on to have a colonized newborn. Of the colonized newborns, the vast majority are going to be asymptomatic, but about 2% of those colonized newborns will go on to develop disease secondary to GBS, including early onset sepsis, pneumonia, and meningitis. So since we know that maternal colonization is a major risk factor for the development of early onset sepsis in neonates, the guidelines recommend looking for colonization in mothers late in pregnancy in the 35 to 37 weeks, close to delivery of the infant. So a swab is done of the vagina and rectum. And you can also do self-collection, and this is with a swab. And then you just send it for testing to see if GBS is present or not. So intrapartum prophylaxis against GBS, so treating mom for GBS during labor and delivery, is indicated in a few scenarios. So one of them is from this testing. If there's a positive GBS vaginal rectal screen culture in late gestation during the current pregnancy, then it is recommended. If you've had an infant previously with invasive GBS, it is recommended, regardless of the results of the screen. Any GBS bacteriuria during any trimester of the current pregnancy, it is recommended. Unknown GBS status at the onset of labor, so the culture wasn't done or incomplete or the results are unknown, and any of the following. So unknown GBS plus deliveries at less than 37 weeks of gestation. You have a prolonged rupture of membranes greater than or equal to 18 hours. You have an intrapartum temperature greater than 100.4, or you have an intrapartum PCR, nucleic acid amplification test, that is positive for GBS. Those are the scenarios where intrapartum prophylaxis is indicated. Intrapartum prophylaxis is not indicated in scenarios where there was a previous pregnancy with a positive GBS screening culture, unless, of course, the culture was also positive during this pregnancy. If there was a planned cesarean section performed in the absence of labor or membrane of ruptures, regardless of maternal GBS culture status, and that's because really the risk to the neonate is coming through the vaginal canal. And so if there was no rupture of membrane and a C-section is performed, the risk is very low. And then negative vaginal and rectal GBS screening culture during the current pregnancy, regardless of intrapartum risk factors, it is not indicated. So what about the timing? So this is a favorite board question I find in review of board questions is what is considered adequate timing. And so this is just a little bit of data that helps us to understand why we are so picky about the timing of intrapartum prophylaxis to women before they gave birth. So this is looking at the interval from ampicillin to birth. The second column is looking at the number of GBS carrier mothers. And the third column is looking at the number of GBS colonized babies. So here in this first row, we can see that in the controls, so none of these women received ampicillin. Of the 209 women who were GBS carrier mothers, 97 of their babies, so 47%, became GBS colonized. If ampicillin was given less than 1 hour prior to delivery, a large number, 43% of babies, were still colonized. 1 to 2 hours, 19%, 2 to 4 hours, 2.4%, and then greater than or equal to 4 hours, 0.9%. So the timing was actually really important to determine whether infants would become colonized or not, and the risk to the infant then. Okay, this is a very wordy slide, and I apologize for that. But I do just want to go through the algorithm for the secondary prevention of early onset GBS, because this is something that is very important in pediatrics. So we're going to start up here at the corner. Let me see if I can get a pen. So we're going to start here with signs of neonatal sepsis. So obviously, if you have a neonate in front of you who is acting septic, you don't bother with the rest of this mess. you just move on and do a full diagnostic eval and begin presumptive antimicrobial therapy. Okay, so the baby doesn't appear septic to you. No. Next thing we do is look at risk factors in the mom. Was there maternal fever intrapartum? If the answer is yes, you do a limited evaluation and antimicrobial therapy. If the answer is no, let's go on to GBS prophylaxis. If GBS prophylaxis was indeed indicated, yes, and the mother received IV penicillin, ampicillin, or cefazolin. These are the only, for the purposes of this algorithm, these are the only appropriate antibiotic therapies for GBS for the purposes of the algorithm. Penicillin, ampicillin, or cefazolin, and it has to be administered greater than or equal to 4 hours before delivery. So if the answer is yes, and the baby's otherwise well-appearing, mom was afebrile, you can just perform observation. If the answer is no, she did not receive adequate therapy, then you go on to look at other risk factors. Is the baby greater than or equal to 37 weeks gestation? Was there no prolonged rupture of membranes? If it's low risk, you can observe. If they're high risk, because of either of those things, you perform an evaluation and you perform a prolonged observation. So this is one way to evaluate the risk of early onset GBS for neonate. Another way to do it is with the neonatal early onset sepsis calculator. And this was developed initially out of a large hospital system. And essentially what they did is went back and looked at the risk of developing sepsis based on various risk factors. And so you go in and you put in all of these variables that are for your infant. So rupture of membranes, maternal GBS status, highest maternal antepartum temperature, type of intrapartum antibiotics, and then it's going to spit out a risk of early onset sepsis at birth. And then it's going to add on the risk after the clinical exam. So if the child is well appearing, if it's equivocal, or if there's clinical illness, and then it'll give you some clinical recommendations based off of that. Okay, so let's talk about disease in infants. So early onset disease, characterized by respiratory distress. This is a common common finding is, for example, a very tachypnic infant with no clear indication for the tachypnea. Apnea is also fairly common. Shock, pneumonia, and less often meningitis. Late onset disease is typically manifested as occult bacteremia or meningitis, and focal infections like osteomyelitis, septic arthritis, and cellulitis. Ampicillin and gentamicin is the initial presumptive treatment of choice for a newborn infant with suspected invasive infection with GBS. So the ampicillin is there to cover GBS, and the gentamicin provides synergy. And we're talking about GBS here. Ampicillin and gentamicin are also appropriate therapies for empiric therapy for any early onset sepsis for coverage for most of the causative organisms. So including good gram-negative coverage if diagnosis is not known at the time of presentation, which most of the time it's not. And then it's important to note that aminoglycosides have no coverage of GBS alone. So you don't give gentamicin alone. It does provide synergy, though, for ampicillin to essentially be more effective. Once GBS is proven, you can change to penicillin or you can stay with ampicillin, and those alone are appropriate therapy for GBS. Duration of treatment is dependent on the syndrome. So if it's sepsis alone, 10 days. Meningitis, it's 14 to 21 days, depending on who you talk to in your guidelines. Osteo or septic arthritis is longer, 21 to 28 days. And then ventriculitis is at least 28 days. If there's a multiple birth, then you need to observe the birth mates closely and treat presumptively if there's signs of illness.